So today we're going to discuss consent and decision making in relation to transition, especially with young people of a particular age from 16 and above. I'll first start by introducing myself. I'm Laura Adiefa. I'm the Learning Disability and Autism Nurse for BHRUT, covering both sites, and I have with me.
I'm Val Marling. I'm an Adult Safeguarding Advisor and I specialise in the Mental Capacity Act and Deprivation of Liberty Safeguards, and I cover both sites too.
So I thought I'll first start by defining what the transition age is. So according to the NICE guidelines, transition should start from children's services to adulthood from the age of 14 to 16. And I guess the important thing is with consent and decision making, it's really important for families as well as the young person. Parents often feel that they've made all the decisions about their young person's life for so long, because they've got parental responsibility. And I guess the first question would be, how does this differ when that young person becomes 16 in relation to their decision making and consent?
Okay, well the reason that it changes is because the Mental Capacity Act comes into force, if you like, at age 16. So whereas you said, Laura, that until 16 things are going forward on parental responsibility, after that the Mental Capacity Act applies. And we're talking about the young person's ability to give consent themselves. Okay, the law says that if we can support somebody of 16, 17 and above to make a decision, then they should be able to do so. So it would be about assessing the young person's capacity and then seeing whether they could proceed on their own consent. There's a few things that we need to consider. One is if the young person's been given enough information to make a decision, because obviously you can only make a decision about something if you know what's involved. It's also important that the young person doesn't feel under pressure at all. They're not feeling like they have to make the same decision their parent would maybe make, or their carers. So we call that duress. We have to be sure that the young person is not under duress. They're free to make a decision themselves, and that also they can share with other people the decision that they've made.
So what happens when a young person with a learning disability is 16 or above in terms of wanting to make a decision or their capacity being assessed? What does that look like?
What would happen really, what that would feel like to the young person is that the doctor or the nurse or whoever is suggesting the care would have a conversation with them about it, but it would be a particular sort of conversation because it would be what we would call a mental capacity assessment. And during that conversation, the young person would have information provided to them, and then it would be about them showing the staff member that they could do 4 things. And those 4 things are: understand the information about the decision they have to make, to be able to remember the information while they're having that conversation about the care or the treatment, to be able to do what we call balance or weigh up. And that's about thinking what would be the good things about having this done and what might be the risks or the less good things about it, and making a decision, thinking about those 2 things. And the 4th thing is communicating their decision. That can be verbally, or it could be maybe using some sort of communication skill like Makaton, or possibly even pointing to illustrations. It's really important that we gave the young person the chance to communicate however is most comfortable for them. But the assessment, the mental capacity assessment, would be looking at whether they could do all 4 of those things. So that's understand, retain, balance and communicate. At the end of the assessment, a decision would be made whether they did have capacity to make the decision or whether we term it they lack capacity to make that decision, and then there will be a way forward that we'll talk about in a minute.
So for parents who have always been involved in their young person's life and making decisions, especially around care and treatment, how can they be reassured that there will still be a level of some involvement even if that young person can make a decision for themselves?
My expectation would very much be that parents who have been involved until the age of 16, very closely involved and very knowledgeable about their child's care, would continue to be involved. and would continue to be very much spoken with by healthcare professionals. So that should not stop. And if that does stop, then I would, parents should raise that with healthcare professionals, that they have a concern. So I hope that is maybe reassuring in a way that you are not suddenly going to be shut out from decisions made about your child. However, the Mental Capacity Act does mean that if your child does have capacity to make a decision about some care or treatment, that they would by law be entitled to make that decision. So it would not be that parents are not spoken with, but it is, if there may be some not so complicated decision and it empowers your child. They are 16, they are coming towards adulthood, and they would have the same rights as everybody else to make a decision. So I think in that way it's a really positive thing, but to offer that reassurance that definitely involved parents should still very much be a part of that decision making.
Absolutely. So what happens if someone who's got a learning disability or severe complex needs doesn't have capacity to make decisions for themselves and are of the age of 16 or above?
I think it's simplest to talk about the age of 16 and 17. Okay, now between 16 and 17, it's a little bit confusing perhaps at first to think about, because there's actually two routes that decision making can take for 16 and 17-year-olds. One is to continue to seek parental consent. So it will be a continuation of what parents are used to up until the age of 16, and the clinicians may be happy to say until somebody reaches 18 that they will speak with parents and will go with the decisions that they are making. However, there is also another way that things can proceed at 16 or 17, and this is called best interests decision making. And what that means is, because the young person lacks capacity, the decision making would go more to the healthcare professionals, and they would look at the whole situation. They would talk with parents, they would talk with the young person and see what they were wanting, because although they may lack capacity to make the decision, they may still be very clearly expressing their preference, and that's really important to bear in mind. They would also think about the intrusion, the complexity, how burdensome, if you like, the intervention is, and they would put everything into what you could call a best interest making pot, if you like, and then come up with a decision that I would very much hope would usually be a decision that the parents are happy with and that they agree with, and that would be called the best interest decision. But the point is, if they're not seeking parental consent for 16 and 17-year-olds, the person that makes the final best interest decision is the healthcare practitioner. And although they're consulting with family, actually they're taking that decision-making power. So I think it's a little bit complicated, so it's quite a lot of information, but it's just important to remember for this age group of 16 and 17, it may be that parents will not really notice any difference, or it may be that they start to hear about this best interest decision. They should be very much involved, but it would be very much more to the healthcare professionals side of things. So I hope that makes sense. It's always, there's some more information maybe people can seek afterwards if they're a little bit confused by that.
Thank you, that's helpful. So in regards to the best interest meeting, for a young person, if they need to have a particular procedure, for example, have their appendix removed, what would the best interest meeting involve? Who might it involve?
So a best interest meeting is an opportunity to get the key people involved in the young person's care together, to give everybody an opportunity to share their knowledge of the young person, to share what's involved in the procedure, to make a plan for how to make it as positive and as stress-free as possible for the young person. So it's really, really important. This is where the parents' contribution is absolutely crucial, because they have such a lived experience and knowledge of the young person and what particularly helps them when they're stressed, when they have new things happening, and how this can inform the professionals who are going to be carrying out the procedure. The people that I would expect to be present at the meeting would be, of course, parents, the young person, if that's comfortable for them, maybe even for part of the meeting. I would expect adjustments to be made at the meeting so that they can be fully involved. we would have the doctor who is proposing this appendix, did we say? Yes. I would expect perhaps a senior nurse from the clinical area who would be caring for the young person, whether, before and after they've had the procedure. If they are, for example, resident at a care home for any or part of the week, I would hope that a key carer would be present there. And you need somebody to take minutes of the meeting, preferably somebody who's not too involved in the discussion, so that they can make an accurate record of what's happened. And this would be shared with the people after the meeting. So you've got a really nice information source to show everybody clearly what's going to be happening and the decisions that have been made. In these strange COVID times, it may not always be possible to have everybody in the same room at the same time, but we have things like video conferencing and even a loudspeaker phone call. So again, the ideal would be that people were together at the same time. But if even that is difficult, it may be that different people could be consulted at different times. Maybe a parent is at work, for example. It may be possible that there could be a phone call in the evening, maybe from a clinician, to get some information and key points from them, their contribution to the meeting. That can all be pulled together. And so out of it, you would have what is called a best interest decision that hopefully everybody is agreeable to, and that will all plan how you're going to move forward when the procedure takes place.
That's really good. I think you've clearly kind of outlined what that looks like for me, so thank you, that's really helpful. So in terms of decision making, what happens when that young person with a learning disability reaches the age of 18?
So at 18, a young person actually is an adult. 18 is the age in this country at which everybody becomes an adult, regardless of whether you've got a learning disability or not. So when we've been talking about these two routes, if you like, that things can take, which is 16 and 17-year-olds still having their consent to their care provided via parental responsibility, parental consent, or this best interest decisions route. At the age of 18, it is no longer parental consent that applies. It is always the best interest decision route. So what I've just described in terms of best interest meetings, and if we're thinking about having the capacity assessment, this will always apply 18 and above. But to revisit, as I always am, that this does not mean that the involvement of parents is diminished. It will remain the case that parents should always be consulted. The reason I don't say always is we have to have the proviso that if there's something really urgent or life-threatening, that you would not be having a consultation process, that healthcare professionals would be providing urgent care, and that would apply to everybody. So that is why I can't always say we consult with parents, because sometimes we have to act urgently. But other than that sharing of information, that consultation should always take place.
So what happens if a parent, for example, disagrees or strongly disagrees with a decision that's been made by a clinician or a practitioner about the care of their young person? What options do they have available to them in that situation?
There are options, because as I was saying earlier, the hope is that generally there would be agreement. But of course sometimes there isn't, and sometimes parents feel this very strongly. So the options can be with the healthcare professionals to have, for example, another meeting, or more discussions, maybe one-to-one, for example, with the doctor if it is about the surgical procedure, rather than in that with several people at a meeting. It can be easier one-to-one. They could request, for example, a second opinion from another doctor to seek reassurance whether the choice of the intervention is correct, whether they feel confident in what the medics are suggesting. They can perhaps go and seek extra information themselves, aside from what the healthcare professionals are telling them. So this could be, for example, contacting an organisation like MenCap, or maybe going to somewhere like Citizens Advice Bureau, because they're impartial, they're independent, but they've also got a good knowledge of what best interest procedure is, and what the parents can reasonably expect about their involvement and their decision making to be taken into account. If this is not finding a solution and the parents are still very unhappy, then what can happen is that there can be a referral to what's called the Court of Protection. And the Court of Protection are, as it says, an independent court. They're very, very powerful. They have a high-level decision-making powers for people that lack capacity. And what would happen is that the healthcare professionals would provide a report from their view of what they think should happen, and then the parents would provide their view and their opinion, and the Court of Protection would make an independent decision. So it would take it away from the hospital, and they would make, and their decision would be final. So it is several steps away, but it is an option, and it's good that parents do know if things are not resolved locally, that they can request that things go externally to the Court of Protection.
Is there anything else before we conclude this session that you feel is quite important?
I suppose, Laura, really what I'd just like to finish with is for people to remember the Mental Capacity Act. It is the law that is applying for young people that are transitioning and need to make decisions about their care and treatment. So if you remember what the law is called, and then there's a lot of really good information out there that can be accessed. MENCAP have excellent, clear, very useful information about the Mental Capacity Act. As a trust, we also have leaflets that talk about the Act and best interest decision making in standard format and best interests that people can access. So don't be afraid to ask. Staff should support you very much in this process, but it is at the end of the day about your children being empowered to have the same legal rights as everybody else, and that is really as it should be.
Thank you. So I really hope that from this session that you as parents and as young people have got a real understanding or an idea around decision making and capacity. And I just want you to also know that as healthcare professionals, as practitioners or doctors making decisions, that we are really about putting that child or young person at the heart of every decision. And we really want to make sure that the best decision is made for that young person. And it's about no decision about me without me. So I just want to say, if there's any more information that you might need, please feel free to contact us, and we'll be able to advise accordingly as well. Thank you.